It's a great pleasure for me to introduce this parliamentary briefing. Over the past 3 years or so, ASMS has conducted several important pieces of research amongst our members, the medical and dental specialists in New Zealand hospitals. Thanks to this research, we now know that here in New Zealand, our members have some of the highest rates of work-related burnout in the world, whilst also suffering from high levels of presenteeism or the pressure to turn up to work when sick. We also know that experiencing or witnessing bullying is a real and common issue for our workforce. These issues most likely result from overwork and system-wide understaffing in our hospitals. Our survey data suggests that New Zealand DHBs have around a 24% shortage of medical and dental specialists to deal with the current workload. In real terms, this means we need at least 1,000 more specialists to deal with the number of patients we see right now, let alone to attend to all of the patients who are not being seen out there in our community. The focus of today's briefing, however, is that in all of these disturbing findings, the situation with women is consistently even worse than it is for men. Women are more likely to work through illness than their male counterparts, and women are more likely to report as self-report as bullied. When we look at the burnout statistics, whilst the rate of burnout amongst young male hospital specialists is striking at 50%, the rate amongst young female specialists is even more horrendous at 71%. To put this in the patient context, when doctors have burnout, they're not able to provide the empathy and compassion that's required for good patient outcomes. So over half of our patients in New Zealand may not be getting the compassionate medical care from their doctors that they deserve because their doctors are too overworked. The research today is to set out to explore the reasons why the well-being of women, in particular in the New Zealand senior medical workforce, is so at risk. Against a backdrop of increasing workforce pressures, growing clinical demands and high patient acuity, what aspects of medical culture may be unwittingly contributing to these statistics and what might need to change? The work that ASMS is doing in this area complements international research, highlighting systemic problems with gender inequity in medicine. Worldwide, there are many examples of gender inequity in specialist salary scales and in career progression. What we do know is that a key driver for this inequity is implicit gender bias based on gender schemas, or our culturally determined expectations of how women and men behave. These gender biases and schemas are largely subconscious, and they shape both women and men's expectations of how women and men ought to behave. To address gender inequity properly, we need to fully recognise the presence and impact of implicit gender bias. These are issues that everyone needs to address, and I would strongly recommend that you all test your own implicit gender bias by doing the Harvard Implicit Bias Test online. Very easy to find. The results are often confronting. Lastly, there is increasing competition amongst countries worldwide to employ enough senior medical specialists to serve the patient population. New Zealand is highly dependent on foreign-trained international medical graduates because we struggle to retain our own graduates. The research presented today matters if we are serious about making New Zealand's public health system the workplace of choice for New Zealand graduates and for international medical graduates in an increasingly competitive medical skills market. Addressing cultural change in the workplace will pay dividends in terms of elevating the significance of staff well-being. It is well recognised that respect, compassion and inclusion are vital to achieving high-quality patient care. ASMS is very fortunate to have Dr. Charlotte Chambers doing this research and analysis for us. She's been the main contributor for many of our research projects in recent years and has developed a reputation for high-quality, high-relevance research. I won't say more about this project as Charlie will do a much better job than I, but before Charlie briefs us, however, it's my great pleasure to introduce the Honourable Julianne Genter, our Minister for Women and Associate Minister for Health and Associate Minister for Transport, to address us. Thanks, Julianne.
Tēnā koutou, tēnā tātou katoa, nā mihi nui kia koutou. Thank you so much for the warm welcome, and I'd really like to thank Dr. Charlotte Chambers, Director of Policy and Research, for organizing this event and for the invitation to this session on how women themselves articulate their experience as doctors. This really matters to me personally, and I think it matters to the government. We all recognize that right across our society, there are better ways of doing things and that we aren't getting the outcomes that we want from the old way of doing things. So this is, for example, starting to be addressed in our approach to looking at government spending. So we had the well-being budget, which is the first attempt to really try and understand what are the outcomes people are getting, and are they supporting the type of New Zealand that we want, one where no child is growing up in poverty, where everyone has access to a safe, healthy, warm home, where we're not destroying our environment in the medium or long term just for some short-term economic gain. And I think that this theme of well-being, while to some it might sound not as scientific or hard-nosed, actually it is. It's about achieving the outcomes that we want. And so when we look at a profession like medical specialists, this research demonstrates that we aren't necessarily delivering the outcomes we want because we aren't having a framework to address some of the structural inequality that exists in our society and in all professions. And also that when professionals are suffering burnout because on the one hand we have metrics or incentives to continue working, at a certain point the outcome is not what we would want. More work doesn't always equal better work, and it doesn't equal better outcomes for our people. So we have to be driven by what are the changes and what are the structures that are going to deliver the outcomes that we want. In the same year that University of Otago is celebrating its 150th anniversary, I thought it would be useful to reflect on a couple of firsts for New Zealand women and women in medicine. In New Zealand, Emily Cederberg was the first woman to enter the University of Otago in 1891. And while her entry into formal medical training was not reported to be controversial, she no doubt had to contend with significant negative behavior from her male peers. Historically, women were actively prevented and discouraged from medicine. And of course, at the time that she enrolled, women didn't even have the right to vote. 2 years later, in 1893, New Zealand did become the first self-governing country in the world where women fought for and won the right to vote in parliamentary elections. And Emily herself signed the 1893 women's suffrage petition. In 1896, Emily became New Zealand's first female medical graduate and went on to do a postgraduate study before registering as a doctor in 1898. Emily's friend, Margaret Cruikshank, was the second woman to complete a medical course and was New Zealand's first registered female doctor in 1897. Both women paved the way for other women to study medicine. And of course, today, we have more women graduating from medical school than men. 55% of medical graduates are female, which is a better reflection of the society we live in. Fast forward to today, and Dr. Chambers' research sets out to answer the question of why women in medicine, particularly in their 30s, appear to be at greater risk of burnout than their male counterparts. The research highlights the need to understand the well-being of our medical workforce because we have to protect that if we're going to deliver well-being for their patients and the people that they work with, also their other colleagues. It's important that we acknowledge the significance of these issues and make changes in the culture of medicine to meet the expectations of the doctors and of the patients. I know many of you, probably everyone in the room, has multiple examples of where inequalities in gender occur in our health and disability system, and not just inequalities in gender. What we've found right across the board is that while there is inequality in gender, it's even worse for some women when there is an intersection of ethnicity and gender or disability and gender. So disabled women, Māori women, Pacifica women, other women of color or migrant refugee women to New Zealand suffer an even greater level of discrimination and level of inequality in pay and outcomes. And if we're going to address this, we have to recognize that it exists and start setting out some really practical evidence-based measures to change the structure. And achieving equity is a strong focus for this government. Equity in health outcomes and closing the gender pay gap are two of those. The workforce of the future needs to better reflect the community it's serving. It's trained appropriately and is able to achieve better work-life balance. Recently, I released or launched a report called Addressing the Gender Pay Gap and Driving Women's Representation in Senior Leadership. This was a report from the Champions of Change group, who is a alliance of large businesses and private sector employers who have agreed to work together to come up with some of the ways we can report on gender pay gap and ethnicity gaps, and so that they can start taking specific steps to address that inequality in their own organizations. And I'd say that right across society, we all need to do more to have fairness in our workplace, to close the gender pay gap. We are seeing good progress in many areas, but we need to make sure the progress is of benefit to all women, including Wahine Maori, Pacifica women, disabled women, older women, new mothers, trans women, and migrant women. The government of course, has a significant work program with unions, employment organizations, and other key stakeholders to ensure that we're delivering better outcomes for our health system. So the increase in funding so far, I can report, has resulted in nearly 1,500 more DHB nurses since the government took office, over 100 more midwives, 582 more doctors, and 531 more allied health workers. I think the midwifery and the nursing accords are good examples of how the government can work closely to support the health workforce. The nursing accord has resulted in an agreement to ensure placements of all newly graduated nurses within 6 months of graduation into a nurse entry to practice program, with a view to reducing that time frame to 3 months over time. And we've got a package of initiatives being proposed by the Midwifery Accord Operational Group, which include, for example, a coordinated DHB recruitment campaign, a national DHB information package for final year midwifery students, cultural and pastoral support for midwives, and the development of recognized career pathways. In 2018, the DHBs and A2 settled a collective agreement that significantly increased support service pay rates. So I'd like to thank all of you for attending today. Really looking forward to a presentation of the report and research. And again, thanks to Dr. Chambers for this excellent work. The work all of you do is incredibly important to improving the health and equity of all New Zealanders. So I thank you for that. Nō reira, tēnā koutou, tēnā tātou katoa.
Thank you so much, Julianne, for that welcome. It feels strange being referred to as Dr. Chambers, but I'll own it. Thank you to all of you for making time in your busy morning to come along today. I see that Liz and Co are back, so we actually have copies of the report for you guys to grab on your way out. And on the screen are some selection of quotes and some images that I've used in the report, just to give you a taster of the material inside. I just want to acknowledge as well that this research has been a really long time in the making. It was actually nearly 2 years ago that I first started trotting around the country and interviewing our fabulous women members. It was a pretty grueling process, I have to acknowledge. I actually ended up taking a 6-month break from paid work, partly because of some of the issues that I was researching at the time. It was almost like holding a mirror up for many of us professional women who are trying to juggle significant domestic commitments as well as our fabulous careers. So I want to start today with a story. It's a real story that Dr. Katie Benn, one of our ASMS executive, relayed to me around the time of conference last year. And she reported that she was at the time working in a really busy emergency department. I think this was actually in the UK. And a patient turned up. Now, despite how busy and hectic it was in the morning, this patient was rapidly triaged by a nurse. She was assessed by a registrar, she was seen by a house surgeon, and she was even reviewed by the emergency medicine specialist. But this woman refused to leave. And after a while, the doctors sent in a medical student to go in and check on this woman. And as soon as this woman saw the medical student, she exclaimed, Oh, thank goodness. You wouldn't believe how bloody long I've been waiting to see a doctor. So it's a real story, and it may read like a riddle, but hopefully the reason you've worked out is that all the doctors, apart from the medical student, were female. So this is a classic example of the subtle but pervasive gender bias that many of our women doctors, our medical specialists face on a daily basis. And for the 14 women who participated in the research that we're launching today, their stories reveal the often subtle but pervasive types of inequities that they face on a daily basis, as well as the social stereotypes and expectations that are layered on top of their gender and the way in which this matters for the way that they're treated by their patients, by their colleagues, and the other medical staff that they interact with. Most of the women who I spoke to actually laughed off the fact that on a daily basis they would be mistaken as a nurse. And they were very quick to say to me, there's nothing wrong with being mistaken for a nurse, it's just that I'm actually a doctor. They would also laugh and sort of shrug off their frustration with the fact that when they were doing ward rounds, if there was one, often a lone male medical student in their posse, the patients would direct their questions to the medical student. The 11 women who were parents in my research were fairly resigned to the fact that it was more often than not their responsibility to rearrange their very hectic, busy working day in order to accommodate unexpected events like having a child fall sick or get hurt at school. Even though some of them had non-medical spouses, more often than not it was they who would receive the phone call to say, your daughter's sick, or so on. The amazing surgeons who I interviewed in my research were used to dealing with subtle and sometimes not so subtle pushback from some colleagues and from other nursing staff in response to their presence and often their different way of wanting to train and work in an operating environment. But what I think overwhelmingly is that these small acts of misidentification, the gender-based behavioural assumptions, and the subtle differences in treatment that these women experience really do matter. And I want all of you to think about these small minor acts collectively as representing the additional things that women have to do. It represents the additional emotional labour that women have to do. And particularly for our doctors, they have to work that little bit harder, even though they might not acknowledge it themselves, in order for their presence to be accepted as legitimate medical professionals. And as many other researchers have substantiated, this additional labour, this additional work that women have to perform can impede their efficiency at work. If you're doing a ward round and a patient asks you to fetch a nappy, that means your ward round is going to take significantly longer over time. It means that they're often experiencing an increase in their working hours, and overall carrying this mental load for their other lives as well. It can significantly contribute to their feelings of emotional exhaustion and, as this research has substantiated, their overall propensity to burn out. So what this research suggests is that overwhelmingly, women in medicine face a qualitatively different set of issues and considerations that perhaps their male colleagues don't have to encounter to the same degree. As Murray has already stated, the statistics around well-being paint a fairly stark picture. But one thing I really want to make clear is that this research is not actually about women do. And I thank Angela Bellich for this great one-liner. It's actually about what many men are not doing. It's actually about what our systems, the hospitals that these doctors work in, are failing to do. It's about the outdated structures that these women are working in. So why is it that I'm sure most of our male doctors out there also have children, or if not children, significant domestic commitments? But why is it that they don't seem to experience the same demands on their time? Why is it that there's almost a 21% discrepancy in the likelihood that doctors in their 30s will hit burnout based on their gender? Why is it that women doctors, on average, do work more part-time roles, not as is often the case with their male colleagues because they're picking up private work, but because they're having to split their time between their domestic commitments? Why is it that international research, and I think there's a graph which is rapidly flicking past on that screen, that suggests that if a woman is single, she is less likely to experience emotional exhaustion than if she's married or in a committed relationship. And yet the exact opposite holds true for men. And why is it that the same research finds that if men have children, they are less likely to experience emotional exhaustion, but again, the exact opposite holds true for women. It's like two parallel lines. There is something very different about the experiences of men and women. And here I also want to make an important caveat regarding my work. Although I spend a fair amount of time discussing the challenges faced by the 11 women in my research who have children, I think it's imperative that we actually shift this debate around parenting and responsibility for domestic affairs to be issues of concern for all of us, both men and women. If we're not doing this, then we're actually serving to reinforce these really problematic stereotypes that these are somehow only women's issues. And in this regard, I'm really hopeful that things are changing, and I was really heartened that after giving a very, very early draft presentation on this research, I had two of our male branch officers come up to me after the talk and share with me their experiences and efforts to try and reduce their working hours and have more flexibility in their work patterns because they had children. They just had kids, and they really wanted to spend more time at home to be more active parents. But unfortunately, they were telling me about the pushback that they were getting for these efforts, and unfortunately, it wasn't just coming from their managers as well. I also spend a fair amount discussing the way in which gender bias is interwoven with issues around time. And I spent quite a bit of time reading about the peculiarities of medical time in the research. It's fascinating, and Julianne's already briefly talked about the history of medicine. And it's not insignificant, I think, that medicine developed as a profession that was male-dominated, and it was in many ways structured around how men were able to work as unencumbered individuals. So a core part of the manner in which medicine developed as a profession were this development of the expectation that you'd be able to spend extensive time doing your work, doing your training, quite literally doing your time, and how this was coupled as proving yourself as a legitimate medical professional and as showing your dedication to the profession. But it's not insignificant that the men were able to work in this way because they had somebody at home. And actually, it was only 1987, when I was reading some medical history, Barbara Heslop, who was associated with the medical school at Otago, she reflected on the fact that it was common advice given to male medical students who were interested in taking up a career in surgery that they would be well placed to acquire a wife. She also said that for women wanting to get into surgery, they would also be well advised to acquire a wife at home too. So in the interviews that I conducted, there was a really strong sense of, I struggled to describe it in any other ways other than the temporal primacy, the fact that medical work has to take pride of place, I suppose, in time that you have available. Work is expected to regularly spill over into your personal time. Medicine is not just a job, it is your life, it is a vocation. And I think we have to reflect on the structural factors that also contribute to this, the fact that our doctors are working in incredibly lean, very stretched working environments with growing patient acuity. But more than this, it's the fact that it's not just tacitly acceptable for work to bleed into other parts of a doctor's life, but it's the sense that allowing your work to do this is a necessary and defining feature of what it means to be a good doctor. That's a problem. Because for those who do have significant domestic obligations, it's obvious how this tension between work and life can pose significant practical and emotional issues. And here I was really shocked actually by some of the women who I interviewed who are working less than full-time in terms of the language that they use to describe themselves. And I was really saddened actually to hear these women describing that they felt somehow second class in comparison to their colleagues who are working full-time, who are abiding by that strident norm, that they felt that they were somehow second-class doctors or being a bit of a slacker because they weren't working full-time. Now, as we also know from the research that we've conducted, working really long hours is a strong correlate of burnout. The more hours you work, the more exhausted you are, the more likely you are to hit burnout. But what this research suggests is that because working long hours is ingrained as such a cultural norm in medicine, that if you do try to reduce your hours, as these men were doing, or as some of the women are doing in my work, in order to avoid burnout or because they want to have a sense of balance with their other commitments, this decision is not necessarily going to be protective if it's also accompanied by a sense that you're internalising being somehow a second-class doctor or a bit of a slacker, that you're not pulling your weight, or that you're not demonstrating the same commitment as your colleagues. But also, in this research, there are some glimmers of hope, and I was really heartened to speak to a surgeon in my work who, largely through serendipitous means, and here I think there is a challenge for the colleges who are present to perhaps think about some of these issues, she was able, through serendipitous means, to actually do her training part-time and also work as a specialist part-time in a surgical career. But she was the odd one out. It's not a common model of training, it's not a common model of working, and I actually think we need to do more to make it easier for both men and women who want to work differently to look at these opportunities. But the thing that really struck me was she said working part-time made her a better doctor, because she said it gave her the headspace to focus on her training and to prepare for her exams. She wasn't exhausted the whole time, and that she also felt that she would be more than happy to go above and beyond what she would normally be expected to do, because she really valued each patient that she interacted with as an individual. So, as Julianne's already said, the New Zealand Medical Council data estimates that women will soon outnumber men in the medical workforce. And I actually think we need to celebrate this. We are finally achieving a gender-balanced medical workforce. Please don't use the term, it's a feminised workforce. That is a pejorative term. It is a really problematic term. And I actually suggest to all of you that we need to treat this line, this date, as a line in the sand. And we need to treat this launch today as a call to action. It's my hope, and I don't think I'm wearing rose-tinted glasses, that by 2025, women entering into the medical profession will not be advised by their seniors that perhaps a career in surgery isn't suitable for you if you want to go and have kids, or perhaps training as a cardiologist isn't the best thing for you because you won't be home for Christmas dinners. This is another anecdote that I heard just on my walk here. It's my hope that both men and women working in medicine will be demanding greater flexibility in the way in which they're able to work and the hours of their work, so that they don't feel this pressure to work above and beyond their contracted FTEs, and so that both can play equally active roles in all domestic responsibilities, irrespective of whether or not they have children. And while it's obvious that this is going to necessitate cultural change, I think we can't ignore the fact that it's also going to require significant systematic structural change. This change is not going to happen unless it's accompanied by significant shifts in employment practices and in the working conditions that our doctors experience, and all of this is going to require adequate resourcing in order to achieve. I also want to state for the record that comments from that obstetrics and gynaecology specialist in Australia recently, some of you may have read the news, who said that having more women actually makes a medical workforce more vulnerable. It's a load of bollocks, and it's actually fundamentally misguided. We know that there are significant doctor shortages in DHBs, and we know that this situation is expected to deteriorate. We've been doing this research, which Murray cited, that suggests that at present, of the district health boards that we've surveyed, clinical directors and heads of department estimate there's around a 24% staffing shortfall. But this problem does not inhere in the decisions for women to enter into medicine, and often, but not always, to strive for different ways of working. The problem is not that women and increasingly younger men coming through, this new generation of doctors, are demanding too much. It's rather that medicine continues to be a profession which I think is old-fashioned and archaically structured. So without understanding the significance and the power of gender bias in medicine, efforts to explain why women bear a disproportionate risk of burnout and other indicators of well-being can actually unwittingly serve to reinforce views like this ONG specialist in Australia concerning their legitimacy in medicine. It can also serve to reinforce really problematic explanations that suggest women are struggling in medicine because they're somehow not strong enough or tough enough to cope. The answer here is actually to recalibrate the expectations, especially expectations around hours of work in medicine, so that they can be done by a new generation of doctors. Not a man with a wife at home, but a man or a woman with a working partner and jointly held responsibilities for their domestic environments. But achieving this change requires all of us. That's why we've called for this cross-sector briefing. We all have a responsibility, we all have a part to play in making this change, and we all need to feel like we've got skin in the game. So, to conclude, I want to acknowledge the 14 amazing, really talented, passionate and articulate women who I had the pleasure to interview. And although the report is largely focused on often the negative experiences that these women had, it's not my intent to reinforce a sense of these women as victims, as others, or as somehow irrevocably marginalised. For these women, their identities as doctors is so core to who they are. It embodies the passion, the pleasure, the commitment, and the bloody hard work that has resulted in their successful careers in medicine. They have worked so hard to get to where they are, and it's a role from which they quite rightly derive great pride, passion, pleasure, and joy in performing. I'd like to thank all of them for taking the time in their incredibly hectic schedules to speak with me. Some of the interviews were really long and they were very intimate affairs. I think some of the women told me things that they hadn't had the courage to voice before. And I really hope that their experiences resonate with all of you. I encourage you all to read the report. Copies are at the back. And I also encourage you all to confront the challenges head on and to really think about what your organisations and colleges and bodies can do to make a real difference. Some of the reading may be slightly uncomfortable, but actually I don't apologise for this. If nothing else, I want this report to stimulate robust debate and discussion. We need to confront these challenges head on because I think we all know that our public health system depends on it. Thank you very much for your time today.
Thanks, Charlie. I think you can all see that Charlie's doing a fantastic job of shining a light on these issues that do need to be solved for us to have enough healthy doctors available to treat patients. So thanks for that, Charlie. To wrap up, I'm going to ask Sarah Dalton to come forward. Sarah is currently an industrial officer with ASMS, but on the 1st of January, she takes over from Ian Powell as our next executive director. And so I welcome Sarah to wrap up today's session.
Thanks, Murray. Ata Māria koutou. I'd like to thank our speakers this morning, Minister Genter in particular for hosting this launch and for your work in support of women. This work has been going on for generations. I sometimes wonder if it will ever end, if we ever get to stop and rest. And in the last year, ASMS has recognised some of the history of women in medicine and the work that's been going along through a series of commissioned comics by Sarah Lang, and I would warmly recommend those to you, and they will continue next year. Murray, as our president, thank you so much for your commitment to championing this work. It's really important, and we do thank you for your leadership. And of course, Dr. Charlotte Chambers, Charlie, whose research continues to shed light on a range of issues across hospital medicine and dentistry, and which helps to sharpen our focus on matters of urgent concern. The Women in Medicine Network is a Facebook group comprising nearly 5,000 doctors and medical students, and that offers us daily examples of the lived experiences of our members and other women in the medical workforce, many positive, but a number of which are, to say the least, suboptimal. This health dialogue, Making Up for Being Female, offers specific examples and analysis of a number of these issues, as Charlie has described, and the lived reality for women in medicine. Our policy and research team at ASMS continue to examine burning issues across the senior medical workforce using both quantitative and qualitative lenses. We know that we don't have enough senior doctors currently employed in our DHBs, and we know that climate and culture are not always conducive to providing sustainable work or to support best patient-centred care. Charlie's qualitative work shines a light on what this looks like for a key segment of our members and one segment most affected by burnout. Our data shows that we need these women to stay in medicine and in our public hospitals. It also shows that we need to attract and retain more senior medical officers into our health system. So, where to from here? ASMS has established a standard for sustainable work, which sets out employment and collective agreement provisions and mechanisms which help to eliminate some of the double standards described here. Our clear focus as we head into 2020 is to ensure that frameworks are in place so we can recalibrate the hours and expectations of professions so that they can be done by the new worker, and that the contributions of all our members are seen and valued. Nō reira, tēnā koutou, tēnā rā tātou katoa.